Thank you very much, Adam and Harry, and everyone for coming. It's super nice that you invite me as not that recent convert to HBV anymore, but still someone who relatively recently came to the field. It's also especially exciting that in HBV, people actually care about immunology. In hepatitis C, we were always like the appendix who was the also runs. And only now, after the problem is kind of solved, the immunology became more interesting. So the title you gave me was a bit ambitious, and you can't. I don't know really what it is, the answer, but also it would be too much to cover. So I thought I'd focus on a recent study we published and go in a bit more detail to explain maybe some of the more finer points of it and why this study actually really changed quite a bit in my thinking of functional cure in T cells. So this is just kind of the summary of what everyone thinks. I want to be fast. We all think that T cells are key to control. It's somewhat clear from the depletion experiments in chimpanzees and in acute infection need both CD4 and CD8s to really control the virus. In chronic infection, we don't have this kind of clear evidence, I could say we have none. I mean, there's some idea that there are higher frequencies with better HBV control, but it's not that clear cut actually. And then one problem I'm going to focus today is that CD4 data are really scarce. And that's not just in HBV, that's kind of in all infections because they're even more difficult to study than CD8 T cells. But everyone agrees based on mouse models that control of viruses is most likely not possible without a good CD4 response. So it's not a lack of interest, it's just that it's difficult. And so we have not defined the correlates of T cell protection in HBV, but it's not any different from HCV or HIV, where we also really don't know what makes a difference between a successful and a failing immune response. So this is one of the big challenges of our time, I think, in human immunology to really show what makes a difference. So what does it take for the T cells to achieve functional cure? And I want to separate this a bit. You will see later why I separate this out. I think one is controlling HBV replication, and the second one is eliminating or controlling HBs antigen. And I think if we think about this a little bit more just from the clinical data, there might be very well two different mechanisms at play here. So we started here thinking about, let's look at functional cure. And I was a bit surprised when I came new to the field that in the literature, actually, functional cure has almost not been studied for T cells. So neither adults with acute infection who almost always resolve, but also not the chronic treated or chronic late patients who achieve functional cure have really been analyzed a lot for their T cell responses. So we got cohorts together of all three, including obviously regular chronic patients. And we started with interferon gamma LE spots where we screened over the whole genome, 40 pools of peptides. But what we always like to do is, because especially in hepatitis where the responses are incredibly low frequency, we like to confirm whether what we have is really positive. So we usually go down then to a single peptide, we make lines, we confirm by, sorry, can we go back? We confirm by ICS and that it's really what we have is a specific response, and whether it's CD8 or CD4. And then we use also the exercise to define new epitopes because we are still pretty bad shape when it comes to HBV in terms of epitopes beyond HLA-2 for class 1, but also overall for class 2 epitopes. And so it has really hampered our efforts to study patients with a tetramer technology. So here's what we find. On the left top, you just see the number of positive spots, and from left to right, you see the early resolved patients in acute infection. Then come the chronic patients, which is a mix of patients with or without treatment. In the untreated ones, we have low viremia and we have high viremia. And then on the right, you see functional cure patients after chronic infection. There are only about 10 of those. That's as good as we got at that moment. And you see that, yes, as expected, the early controllers after acute infection have definitely and significantly more positive pools. Some of them, cover more than half of them. The difference between functional cure and regular chronic is not so pronounced. what one can see when one looks a bit on the zero level of the x-axis, that there's many more of the chronic patients who don't have anything. Functional cure patients in maturity have something, but it's not significant. And the same is true when you look at the magnitude. There seems to be a trend. Maybe if you studied even more patients, we would start to see a difference, but it's not clearly different. And then when you look on the right side, you see for the CD4 and CD8 responses, again, from top, acute resolved, and then chronic functional cure, the number of responses we found across the genome in the different cohorts. And you see we found quite a lot in the acute resolved, and it's very minimal in the chronic and also the actually functional cure patients. So this helped us to define quite a few new epitopes, but other than that, we thought we're not that much wiser after this exercise. So we thought, how can we do better? And the problem with the ELISpot is you cannot increase the input number of cells more than like 200, 250,000 per assay. And this is just not enough for viral hepatitis, we think, in most instances. So we thought, let's do ICS. So intracellular cytokine staining is maybe sometimes a bit less sensitive, but you can use 10, 20, 40 million cells, which you did here, which obviously, for those of you who design trials, is not what you want to hear, because it's a lot of cells. But it does work. And you see here, CD4 and CD8 responses left and right, again, the same order, acute resolved, chronic, functional cure from top to bottom. And you see that, on the CD4 side, we have here a couple, and these are really, because we used per condition 10 million cells, you see really, really distinct cloud. And I think this is really positive, whereas often in the ICS, one is sometimes doubtful whether a few dots are really something or not. And you see even more on the CD8 side. This is TNF, this is interferon gamma. And the next one shows you IL-2. And I just showed this because I mentioned earlier that Rafi Ahmed showed that with IL-2 you can rescue these deeply exhausted cells. And indeed, now we see here, on the CD4 side, and only CD4 cells really make IL-2. We see it in acute recovered. We see also an example in this one patient in functional cure. And if we summarize this data, first for the CD8 cells, you see the frequencies, and one is core specific, that's the triangles, and around you have the envelope specifics. You do see, we see a bit more in the acute resolvers, but overall there's actually nothing really that significant for all the different cytokines. So on the CD8 side, actually, the difference is rather mild. I think, again, more patients would have helped us to see differences, but it's not striking. Whereas in the same patients, when you do it for the CD4 side, here we see pretty clear differences. Again, the strongest difference is the acute resolve, but these are only a few months after they control virus. It's maybe not surprising that you still have higher frequencies. But now, on the CD4 side, we also see the functional cure patients having significantly more responses. So this was kind of exciting for us, and what I also want to mention, the chronic patients here, this subgroup, in contrast to what I showed you earlier, these are all on treatment. So obviously we now need to really make bigger studies where we have patients on treatment, IC patients, low, high viral load, to see, but I can tell you that, or we'll see in the next part of the study, that we actually find CD4 T cells very little across all different levels of control, and with and without treatment. So based on the information we had, we were now able to do for the first time CD4 tetramers to really analyze these cells directly at Scrivo. You see the technology has vastly improved over the last 2 years, get really nice cloud of positive cells. This is really hard to. And so we wanted to look and compare again these different populations. So we had obviously could only take the patients who have the respective HLA alleles so that we can test. But you see here that clearly acute resolved and functional cure, the vast majority, over 80% of the patients actually that we could test also had a response, whereas in chronic infection it's rather low. And in patients with vaccination, we also found 50% of cases a tetramer response. So kind of really confirming with an assay that's function independent, that really is physical detectability, that the lack of response in chronic is not dysfunctional cells. What we really have here is a lack of these cells. Now, could they be present, but still at a lower frequency. It's quite possible. We already had to enrich here using magnetic bead enrichment columns. We started with like 20, 30 million cells in the chronic patients, so that's a lot. We're trying to get now some leukapheresis samples for patients to see whether maybe reliably we can still, and that's quite possible to me, that we will see responses even in more chronics, but they're just so incredibly low frequency. But I think that's an important question. Is this something that's just really, really low, or is it absent? So when we then look a bit more granular, this just shows you the 6 different tetramers we had. You see on the right, 3 were envelope, and 3 are core, and then for each patient you see kind of the percentage of assays we ran and how much they were positive, and you see pretty much in acute infection, most assays are positive. In chronic infection, we tested a lot of patients, it was really very little. And in chronic HBs antigen negative patients, it's not a ton of patients, but all but 1 assay was positive. So we do think it's very indicative that this is quite frequent. And the second point I want to make here is that it's actually envelope responses that are the most common. And from the CD8 side, people have been missing the envelope response, and we have really a hard time finding them. Even now that we look really deeply again with enrichment, we still don't find them a lot. But on the CD4 side, that seems different. And so I know that some ideas about vaccination, for example, people have thought, let's leave the envelope out. Maybe it's useless, but actually I think most likely we need the envelope also for the CD8s, because obviously all the adult resolvers also have CD8 response against envelope. So we do think that this might actually be a key difference in that chronic patients don't have, it shouldn't be a sign to leave it out. It should be most likely be a sign to see what we can do in terms of envelope responses. This allows us now to do a bit of phenotyping. I don't want to dwell too much about this because the numbers are just still really, really small. But you see that just in the blue box, you have the direct comparison on the left, the chronic patients on the right. You have the functional cure chronic patients. And you just see here on top, that the, oops, sorry, this is not very good. You see that, you have mostly effector memory cells in one group, and then central memory is what's really more frequent in the functional cure. And it's less different than, interestingly, when you look at activation marker like CD38, or you look at PD1, which we don't call an exhaustion marker because it's an activation marker as well. You see a much more heterogeneous pattern. It's not very clear. In HCV, for example, every CD4 T cell expresses PD1. Here it's a bit more mixed. But you do note that in the chronic patients, the red dot is actually a patient who we followed from adult acute into chronic infection, the first one we saw like this. So it's relatively early chronic. And you see another patient with an untreated high viral load. So they seem to still be more activated and also have higher expression levels of PD1. So PD1 might also be an interesting molecule on this side. So I want to close now this part here by saying we do really think that functional cure is strongly associated with the presence of potentially resurrected, we assume, HBV-specific CD4 responses. What do? Do they help CD8s to be better functionally, or is it mainly, or both, the support for B cells and antibodies? Are the chronic patients that actually do have CD4 response, are they more likely, or maybe the only ones who can achieve cure if we resurrect these cells? Or did we indeed, as I said earlier, only really see the tip of this, and most chronic patients will have the response? It's just too low for us to detect right now. Obviously, it's still a small data set, but we were quite surprised how relatively clear the data were across different assays, and so we're relatively confident that this is good data. But obviously the amount of blood we need to really do this on a larger scale is a challenge, but I think we need to try and do it at least for a reasonable number of patients so we get a better idea of what's going on. An increase in CD8 responses with functional cure is much less obvious, and so I'm not sure whether they are really the key to improve towards functional cure, and I come to that in a second. In one important question there is also, is the baseline for the CD8s different in IC patients with the treated patients? Because, and I come to that also in the next slide, is if you think about it, IC means replication control by the patient's immune system. And that's not the case in treatment where you use the drug to control it. And so that might be a major difference when you think about immune stimulation, what we need to do. So I just made this little graph to summarize a bit my ideas that I have right now, how this could potentially work. So this is just showing the 4 states, to keep it a bit simple, no E-negative hepatitis, but you see that, IT to immunactive to IC and then functional cure. The major decline is actually from immune tolerant over immunactive to IC. That's where the replication changes dramatically. And then from IC to FC, the difference is not that big anymore, right? They have often rather low replication. It's different for the S antigen that starts also super high. It's obviously not the same scale, but it also starts max in the IT patients, and it comes slowly down. But then from IC to functional cure is where we really see a major difference. And so I think is that maybe 2 different phases, and I'm sure we can argue about this a little bit, but for me the most dramatic difference from functional cure to IC is obviously that we lose S antigen, and it's not so much on the replication side. And so I want to focus on this last transition kind of, and this is obviously one of the other things I really want to highlight is that we have not studied transitions well enough. They're hard to find, but we have now cohorts where we think we can observe people transitioning from one state to the other, and that's going to be much more powerful than our cross-sectional studies. So what could happen here? And I just mentioned earlier, I was wondering about, do we detect HBs antigen really well enough, or do we miss a lot of the complex? And so to me, there could be 2 different scenarios here. It would be, the blue is the total HBs actually that is in the patient, and then you see the red is what we would measure because anti-HBs is in green, right? And so if you have a difference, you have more S antigen than antibody, then you measure a lot of HBs in the blood. And the lower it gets, the more complexes you have, but the less free HBs antigen, and at some point you have kind of functional cure. And so this could be either in this end stage that we've mostly achieved a decline of the HBs antigen, maybe some modest recovery of antibody responses, but it could also be that we actually have not that dramatic a change in HBs antigen production, but a dramatic increase in HBs antibodies. And that would fit kind of with our recent findings in that we have better CD4 response in these patients, that they therefore make better B cells, make better antibodies. And so that really, it might not be in the cell most of the change. Most of the change might be in the immune response that actually allows to complex and kind of neutralize these cells. And this is obviously just a hypothesis right now, but I wanted to put it out because it kind of makes a big difference in kind of how we think about immune treatments. So with that, I just want to acknowledge the people who did this. This work was mostly done by Ruben Hocheven, who's now back in Rotterdam, Susan, who's coming from Rotterdam to us now from the Netherlands, and then Leah and Hannah, 2 postdocs in the lab. And a lot of collaborators obviously contributed to the studies, and thank you very much for your attention.